one or two.
Voice is breaking down. Come again.
Sir. Now, sir, audible, sir.
Yes, it's audible now.
Most of the labeling parts I know, but only one or two I don't know, sir.
Okay, fine. So I will give a small glance. I'm not going to tell you so deep and all. Okay, I will tell you.
Okay, sir.
Okay. As we know, skin is made up of epidermis, dermis, and hypodermis. Okay, epidermis otherwise called as subcutaneous layer. Then followed by that we have muscle. Before the muscle we have fascia, subfascia, other structures. Most if you see when we talk about skin means dermis, epidermis, and hypodermis, which means subcutaneous layer. Subcutaneous layer is very mandatory. These three layers. Okay. Then apart from that, in each we do have sweat pores, nerves, air shaft, then sebaceous gland and hair follicles, adipocytes, okay, which will store adipose tissues, okay. So now this is a basic structure of the skin, and we will be seeing these are the headers and sections and subsections which are present in the surgery part, in the surgery in the integumentary system, okay. So what are we seeing in the green color, red color? Those are going to be the header and subheader in the section surgery in the subsection of integumentary system. Then first part is biopsy. What is biopsy? So very simple in short form, collecting of some small sample of tissue or bone. Tissue can be anything. It can be muscle tissue, or it can be soft tissue, or it can be a bone tissue or bone marrow tissue. Anything it can be, or any cells or fluid from the body for the examining purpose. Okay, through the microscope or through the pathological method, they will be able to identify what is the abnormality or what is the problem you are facing and what is the issues you have in your body. Okay, that is what the biopsy stands for. Basically, we do have different types of biopsy. What you're seeing here, say shave biopsy, punch biopsy, incisional biopsy, and excisional needle biopsy, endoscopic, and bone marrow biopsy. But when it comes for the aspect of integumentary system in the coding, okay, in our coding section, it is going to be majorly three types. One is fine needle aspiration, and second thing is core needle aspiration, and third thing is surgical biopsy. Here, this core needle aspiration and fine needle aspiration and the core needle biopsy both are comes under the needle biopsy. Whereas surgical biopsy, those are like punch biopsy, incisional biopsy, and shave biopsy. Otherwise, sometimes we call it as a tangential biopsy also. Okay, these are the three different biopsies involved in the surgical biopsy. Apart from that, is endoscopic biopsy and the bone marrow biopsy. Depending on the procedure, they may use, but they are not categorized under the these three types of biopsies in the integumentary system. Okay, coming for the next one. So anyway, we are going to see the each biopsy little further. Okay, so I am not giving a much explanation or definitions here. When we are seeing one by one, we'll have a clear picture on them. Next thing is like, as I told, just to give you the picture, how the incisional biopsy and excisional biopsy and the punch and the fine needle aspirations will be there, just to provide a general idea on that. Okay, and how the samples are collected. As I told, fine needle, core needle, and excisional and incisional, and their difference and goals. So, goals and the codes. Just I given the table here. Nothing else is there to explain in this slide. Then fine needle biopsy. Okay, so in the fine needle biopsy, what they do is like they use a large gauge. Okay, the large gauge needle, which will be they collect a fluid. Okay, fluid sample from your body. It can be any place. Most if you see this aspiration, fine needle aspiration is always done in your vertebra. Okay, so they will collect a liquid part and they will put it in the pathological report for making the slide, and they will come for the conclusion. And when they're doing the aspiration, they use a guidance. Okay, based on the guidance and based on the what needle they are using, we have the different set of codes. So we'll be discussing that as well. Then core needle biopsy, a small sample will be collected. Okay, they will send it for the cytological or histopathological examination to identify what is the issue. Okay, so this is a picture which shows how the sample will be collected. It can be any structures, any part, where they will be able to collect the sample by using the core needle. Okay, that needle which will be little more larger, which collect a sample. Then this is the major guidelines. So how I'm going to code the fine needle and how I'm going to code the core needle aspiration and fine needle aspiration, core needle biopsy. So if you see, say for example, if the biopsy, okay, or if the aspiration is done in the one lesion or two lesion, based on that we are going to arrive the code. And when they are arriving the code, the importantly they will be using the guidance. When it comes for the guidance, especially there are different set of guidance are there. ultrasound guidance, CT guidance, MRI guidance. Okay, these are the different set of or fluoroscopic guidance. These are the different set of guidance which will be used to perform the procedures, especially these interventional radiology procedures or some surgeries or some other procedures like invasive procedures, not for the non-invasive procedures, especially for the invasive procedures, they go with certain guidances. Okay, so based on the guidances and what type of guidance they're using, we have the different set of codes. Okay, if you see the table here, I'm talking about lesion 1 and lesion 2. In the lesion 1, fine needle aspiration with ultrasound, and in the lesion 2 also they are going to use the fine needle aspiration with ultrasound. Okay, if you see, we are not coding the ultrasound separately, we are not coding any guidance. It can be a CT guidance or ultrasound guidance separately in the fine needle aspiration, which is bundled. We can other term we can call it also included. Okay, but when it comes for the core needle biopsy, we will be coding the guidance separately. This is the first point, first thumb, remember this. Okay, now how many times the fine needle aspiration is performed? How many time means how many lesions the sample is being collected. If you see the first example, fine needle aspiration with ultrasound guidance, fine needle aspiration of ultrasound guidance for lesion 1 and lesion 2, we have separate codes. Okay, 10005 and 10006. This 10006 is going to be a add-on code. Keep that in the mind. Then second thing is like fine needle aspiration with ultrasound and fine needle aspiration with fluoroscopy. First lesion they have taken with the ultrasound guidance, but the second lesion they have collected. The aspiration is done with the help of fluoroscopy. So we have separate code 10005 and 10007. So here, both the places I am not coding the guidance separately. And third example, if you see, they are taking the lesion 1. Okay, only they are talking about one lesion. Fine needle aspiration with ultrasound, core biopsy with the ultrasound. Here, see, I said you when they're performing the core biopsy with the guidance, we should be coding the guidance separately. But here, since they are performing both the procedures in the one lesion, okay, like fine needle aspiration as well as the core biopsy in the one place, it is possible. Liquid form also they will take, they will collect one sample also. But here, both are same guidance. See, both are ultrasound guidance. Then I don't want to code ultrasound one more time separately, because with one guidance only they are taking the both type of procedure. So in that situation, already the ultrasound guidance is included in the fine needle aspiration. I don't want to code one more time for the core biopsy. Okay, that is a very, very important thing here. If the core biopsy is performed in one more lesion, how we are going to handle that? If the core biopsy is performed in the other lesion. So in that scenario, yes, I need to code the fine needle aspiration with the guidance, the bundle code. Then followed by that, I should be using core biopsy plus whatever the guidance it is. Okay, we have this different set of guidance. If it is ultrasound guidance, we are going to use the ultrasound guidance. Now, I am using the modifier. Can you see XU modifier I'm using here? Why? The main reason I'm using the modifier is to indicate there is a ultrasound guidance performed in the fine needle aspiration. There is a ultrasound guidance performed in the core biopsy. Both are ultrasound, but the different procedure it is performed. That is a distinct procedure it is performed for. So in that situation, I'm using the XU modifier. I cannot go with the encounter because it is performed in the same encounter. Yes, XP is eligible if it is performed by fine needle aspiration is performed by physician A and core biopsy is performed by the physician B. In that situation, yes, I can use XP modifier. XS modifier cannot be used because here I am not addressing any structures here. Why I am using overlap here? Because XC and XP, especially XC is not eligible here and XP is not XP also not eligible here. In that situation, yes, I need to go for the XU, unusual overlap. So when you are applying this 59 modifier, distinct procedure modifier, especially when you are performing the procedures, surgeries, exams, think logically. Okay, here the guidelines, more than the guidelines, your logical brain only will tell you to choose the correct modifier, especially when it comes for XC, XP, XS, and XU. Okay, always people tend to confuse in this modifier, but use your logical brain, apply all the modifier and check the eligibility, then reject 2 or 3 modifiers and come to one modifier for the conclusion. Then one more example, if you see fine needle aspiration with ultrasound, then core needle biopsy with the fluoroscopy. Here again 2 set of codes. Here only the code is going to get changed. Okay, here unusual overlap I'm going to use for the modifier. Yes, you are clear with this table? We are good with this table?
Yes, sir.
Okay, let me go for the next one. Okay, so very simply, keep this thumb rule first. Fine needle, core needle. Fine needle, always guidance is included. Core needle, guidance is not included. If both is performed in one lesion, guidance code I don't want to code separately. If both is performed in different lesion, I need to code both with the modifier. And what type of guidance is using in the core biopsy, that code I need to code separately. As simple as that. Then next one, these are the some of the examples I have provided for the fine needle aspiration. You can see that, okay, when they're doing the aspiration without imaging, when it comes for the ultrasound imaging, without imaging 21, with the ultrasound guidance 5, with the fluoroscopy, it is a 0007, and with the CT guidance 0009, and with the MRI guidance 00100111, where it has a different add-on codes. It has different add-on codes for each additional lesions. Keep that in the mind. Next one, these are the other set of biopsies, which is whatever you're seeing so far is to the level of the skin, integumentary level. When it goes to the different anatomical structures, if it is go for the musculoskeleton, I have the separate code for that. So, which again in the second section will be like a second specialty. We'll be seeing slightly, we'll be seeing about this biopsy, all those things. Okay, and 3 series, 4 series, and 5 series, each system. Okay, if they're doing the biopsy, we have separate code from the skin to till the other integumentary systems, sorry, other anatomical systems, we have separate biopsy code. And here, they're not going to specifically address you about whether it is a core needle or whether it is a fine needle when it comes for the 2 series, 3 series, 4 and 5 series. Okay, they're going to just address, they're going to do the biopsy or aspiration. So in which area they are taking, whether it is a percutaneous layer or whether it is a bone marrow or whether it is any other bone structures or muscle structures, depending on that, we are going to arrive the code. Okay, that is what it goes for the mostly. If you see when it come for other structures, okay, more than the aspiration, they always go for the collecting the sample. Okay, so that is the reason they kept the entire fine needle aspiration in the one series. They did not bring into the other sections. Okay, so here they go for the collecting the sample. That is what they do it in the other sections. Then guidance codes. So these are the different set of guidance which may be used along with the core needle biopsy or core needle sample collection. Okay, it is for ultrasound 76942, and for fluoroscopy guidance and CT guidance and MRI guidance, we have separate code. And if you see the fluoroscopy guidance code, it is going to be the add-on code. Why? Because most of the procedures performed with the help of fluoroscopy, it's going to be bundled. Only in the rare cases, we'll be using the fluoroscopy as a separate guidance code. Otherwise, most of the examination, because it is like almost included procedure only. Fluoroscopy is a kind of X-ray, right? It is like a fluoroscopy, a moving X-ray we can tell, or motion X-ray we can tell. That is what fluoroscopy stands for. So that is the reason it will be always bundled with the other procedures. Then coming to the biopsy concept. Okay, so in the biopsy, the first biopsy what we are going to see is like tangential biopsy. Okay, tangential biopsy. Okay, if you see there, one more they have provided, shave removal. Both are almost similar, where shave, if they're going to you can see like how the shaving will be done, right? They use the blade and they scratch the outer layer for collecting the samples. That is going to be the shave removal. When it comes for the biopsy, they're going to cut and take it. Okay, they're going to cut and take the sample. Okay, tangential biopsy is used when a provider takes partial thickness sample of the epidermis for the diagnostic pathology. Okay, that is a tangential biopsy, and we have two set of codes. One is 11102 for the single lesion, and each additional lesion we are going to use. One second. So coming back, so tangential biopsy, it's for a single lesion. For each additional lesion, we are going to take the separate add-on code. Okay. Then we have one more set of code for the shave removal. That is also one type of collecting of the sample. But what is the difference? Majorly, why we have to do tangential separately and shave separately? Only one purpose. Tangential is performed for the diagnostic purpose, whereas shave removal is performed for the therapeutic purpose. Which means if I see some mass, I collect the mass, then I come to the conclusion what is the problem, whether it is a malignant or it is a lesion or it is a benign or it is a carcinoma in situ, or it is a malignant, I'll come for the conclusion. But when I do the shave removal, it is like I'm collecting the sample for the additional data only, but I'm going to treat it. I know it is already benign, or otherwise I know it is already benign. I know already it is a lesion. Okay, but by collecting the sample, I will be treating that. Simultaneously, I will send the sample to identify whether it is benign only, still it is benign, or it is becoming malignant. Okay, like that, to identify for therapeutic purpose, I'll be using the shave removal. So tangential, I collect the sample and diagnose. Whereas shave removal, already I know what is the condition. I will do the treatment. Then I will go for further collecting the sample and go for further analysis for the same sample which I collected. Okay, that is a major difference on the um, tangential and shave removal. But this comes under the tangential biopsy. Then second thing is like we have the punch biopsy. Punch biopsy, they use a kind of instrument. They take the sample little more further. They go for they go till the epidermis to the dermis layer. Okay, they may not go to the subcutaneous, but it is like outer layer to the subcutaneous. They may collect the sample, which means like they collect a bulk of sample. You can see the picture here, which says how the sample is getting collected, right? So this they use this kind of instrument. And if you see the full thickness of epidermis, dermis, then outer layer of subcutaneous, where it can be good tissues also, it may come. Okay, so that is what they do in the punch biopsy. Okay, so they collect the sample and they send it for the further analysis here also. Here, as I told, they use some, it is called cookie cutter. Okay, sharp needle, sharp material they use and collect the sample. I provided two examples where the samples will be collected for. If you see, patient with the psoriasis and eczema and some drug reaction, in these scenarios, they used to collect the sample by using the punch biopsy. Other suspicious lesion, okay, when they get a suspicious lesion like basal cell carcinoma, to identify that, they also use the punch biopsy. The next and foremost biopsy is incisional biopsy. Here they cut the part of the tissue. Okay, they cut the good tissue and bad tissue simultaneously, and they send it for anything. It can be any tissue. It's like it can be lesion or it can be mass. Okay, they use some kind of scalpel. Okay, they use that instrument scalpel and they will cut the tissue, a partial. They will go attempt to cut a good tissue also, and they will send for the further analysis. Here, they use the same dermis and epidermis level, and they may reach to the subcutaneous, but they will not go into the subcutaneous. Why? Because when they cross the subcutaneous, automatically it will go for the 2 series. Remember, when they reach to the deeper, okay, near to the subfacial region, if they reach next to the subcutaneous level only, you are going to encounter subfacial and facial, then followed by the muscles. Okay, if you are a non-veg eater, you might encounter in the goat, the outer layer will be there, right? So that is called the fascia and subfascia. If they go to that level, automatically it will go for the 2 series. Okay, it will reach to the deep tissue. Then it will, we have to code it, we have to change entire code. It becomes something like I'm taking the core biopsy there. Okay, so here they use the scalp and they will cut the epidermis or dermis layer or till to the subcutaneous layer to send for the further analysis. Okay, so here for integumentary system, we have set of codes, incisional biopsy for single lesion. For each additional lesion, we have 99907 as an add-on code. Then, if it goes like little more further deeper, depending on anatomical site, we have a different set of codes. That is 21550, 2192040, and 2. So there are other more codes are there. These are the some of the codes I included. What happens if it goes for the soft tissue level? Okay. So apart from that, we do not have much things in the incisional biopsy. If you see one example I provided, a 55 years old patient has a large 8 centimeter firm mass deep in the subcutaneous tissue of their thigh. The doctor suspects sarcoma. Okay, so finally what I'm going to take is coming till the level of soft subcutaneous tissue of their thigh. Here, if the biopsy is limited to the skin, dermis and subcutaneous fat, I'm going to use 0006. If it is going to enter to the soft tissue, okay, if I'm going to enter to the soft tissue level, my code is going to get different. That is 27323. Okay, here they are still in the subcutaneous tissue only. They did not go deeper. So I'll be going with the, but still they are telling deep in the subcutaneous tissue. Okay, but I will go with the 11106. So here is a small confusions may come, but be clear. That is the reason we discussed in the first line itself in the anatomy, because till the subcutaneous layer only, it is going to be skin. In some time they may tell deep into the subcutaneous, we shouldn't go like we shouldn't consider that is a subfascia or it is a fascia. Okay, so we should be very clear with that particular structure in the skin. Okay, based on that only we are going to take the codes. The next thing is like how we are going to code. Here we are seeing about tangential biopsy, punch biopsy, and incisional biopsy. In the hierarchy, the bigger one is incisional biopsy, followed by the punch biopsy, followed by the tangential biopsy. Now, if they're doing the tangential biopsy two times, or two times, which means one may primary code and one more is like add-on code. If it's a punch biopsy, three times code primary code, followed by that you can code remaining two times add-on code. Incision also same. But when they perform all these three, make sure we are coding the incisional biopsy first, the primary code first, followed by that tangential biopsy, punch biopsies, add-on code, not the primary code. Okay. So the hierarchy here is incisional, punch, and the tangential. Yes, I agree with that. When I'm coding the primary code, I cannot code all three biopsies primary code. That is not a guidelines here. I need to code incisional biopsies primary code. Other punch biopsy and tangential biopsy code should be the add-on code. Yes, you're clear here? You're able to understand? So if
Yes.
doing the punch biopsy followed by the tangential biopsy two times, code the punch biopsy primary code, then followed by the tangential biopsies add-on codes only we are supposed to use. Okay, not the primary code. So we should be very clear with that. Okay, so based on that only, I have given one example here. If you see the correct code for the incisional biopsy and punch and tangential biopsy are provided. So here how it is coded means if you do one punch biopsy and two tangential biopsy, correct code is one main code followed by that two tangential biopsy will be the add-on code. That is very, very important. Then say I have given the incorrect also was 02. Definitely it will not allow you to, it will trigger you the what is that mu edit, it will trigger. Okay, mutually unlike edit, it will trigger you. Definitely it will get denied. So that is the reason we are using the add-on codes. Then incision and drainage. Okay, incision and drainage is nothing, removing some abscess. Okay, removing some abscess, some liquid, some infected liquid inside your skin, under your skin. Okay, what is the simple? There we have two categories. One is a simple drainage, and the other one is a complicated drainage. Simple drainage, very simple. You can see with your naked eyes. We can tell like it is a self-healing. Say for example, a small abscess which is formed because of the blisters or some kind of infection happens because you can take pimple is one example, which will self-heal. Sometimes if the infection goes little deeper, it is not healing for a long time, we will be using some manual method, manipulation method to remove them. Okay, so we'll put a small incision. Okay, incision, it is not like puncture. Puncture is something it will go deeper. Okay, incision means small hole and remove the abscess and drain them. It will heal automatically. But when it comes for the complicated one, it requires certain criteria like multiple lesion and probe to break up the loculation. Probe means you might have seen some very solidified form of mosses will be there. You need some kind of instrument to cut them. Okay, then only you will be able to open and you can be able to drain them. And extensive packing. Extensive packing is just I will put some cotton and apply some what is it, bandage. Okay, then only I will be able to do the closure. Then drainage placement. Drainage placement. Can you see the tube? How the drainage placement is there? Because the abscess will be formed in very deep, where I need to keep the drainage tube so that the drainage will take 1 or 2 days. And wound closure method also we need to consider. Okay, so simple, it is going to be very simple. When it comes for the complicated, it's going to be very complicated. We have two set of code, 10060 and 10061. That is on the IND, simple and complicated. Then phenodolial cyst incision, simple versus complicated. So phenodolial cyst, you can see the picture. Okay, can you see the picture? Especially backside, it is in a congenital anomaly which you will see it in the most of the infant. Okay, not in our country you might have encountered, but the sacrum dimple we call it as dimple, sacrum dimple, backside our butt, no, glute region, above the glute region there is a connection will be there. We call it as sacral dimple. In that particular location, okay, above the butt, it's kind of cliffed. It won't form completely. You might have seen mouth cliff. The same way, the buttock formation will not be very proper there. In that situation, it forms a cliff kind of formation in the tailbone, okay, where it accumulates with some fluid. Okay, when it will accumulate with fluid and it will become like a cyst. Now, I use two methods. Okay, one is where I can drain the cyst without disturbing the entire structure. Otherwise, I will remove the complete cyst since it becomes the problem for us. Okay, that is a two scenarios. Now we have two different methods to do that also. For removing the, for draining the simple fluid which is accumulated, okay, the fluid which is accumulated in this particular phenolphthalein cyst, I will be using a two methods. One is a simple method and one is a complicated method. Simple method, single layer closure, it will be like I will use the basic drainage. Okay, basic drainage means simple hole incision I will put and I will drain it. That is one method, simple method. Okay, where I will have the single layer closure. Okay, it is a basic level closure, simple closure we can tell. But when it comes for the complicated, I will go in deep. Otherwise, I will have the multiple cyst also. So it is not like one cyst, multiple cyst will be there where I need to put the puncture incision for one cyst, then next cyst, or I need to connect internally to the other cyst. Okay, this all complicated level of drainage will happen. In that scenario, I will be using 10081. For the simple, I will be using 10080. But when it comes for the removing of the cyst, okay, same way when it comes for the remove. So whatever we have seen is a drainage in the cyst. It can be a chances where I can remove the cyst also. In superficial level, if I remove, okay, a single or superficial level, if I remove, it is a simple cyst removal. If I remove multiple, okay, or infected or more than 2 centimeter deep, where I need a multiple closure also directly, go for undermining. Undermining means I need to cut and remove the tissues, that unwanted tissues, waste tissues will be there. I need to remove those infected tissues, and that is called undermining. Sometimes I may have the grafting also. Grafting means I will collect some good tissue and I will attach in this particular area. Grafting also may be done. So that much of complexity will be there. So we have two set of code: complicated, extensive, and complicated. One 1177 is the extensive one, and 11772 is a complicated. Okay, so which level they are going, what level of complications they are telling, or it is just an extensive kind of clearing they do. Based on that, we have the set of code for the phenolphthalein cyst for the simple and complicated. Then foreign body removal. Here also we have simple and complicated. Simple, which are you see in the outside till the subcutaneous layer, dermis, epidermis, subcutaneous tissue. If you see some body, if you remove 10120, if you go into inside to the fascia next to the muscle level, we have to go to the 10121. That is what the foreign body removal of simple and complicated codes. Very simple codes those are. Then wound care coding. What is wound care coding? Wound care is nothing. They are going to clean the wound. Okay, they're going to clean the wound. If I clean the wound only, it will heal faster. Okay, if I don't clean the wound, it will be accumulated with a lot of dead cells, debris. Okay, and what is that? Other infections. This all will get accumulated. So what I do in the wound care is, medically we call it as debridement. Wound care is a general term. Debridement is a proper coding term or medical term. So what is the debridement I do? Removal of death, damage, or infected tissues to promote a healthy tissues. Okay, to promote a healing of the healthy tissues. That is what they do it. Here we have two methods. Okay, one is single wound, otherwise multiple wound. How we are going to handle the single wound? How we are going to handle the multiple wound? Before going to the single wound and multiple wound, we need to aware of one more. Okay, one more, which is also called as non-selective mechanical wound care. Non-selective mechanical wound care, which is like, what is the major difference between the normal wound care and what is the difference between the non-selective mechanical wound care? Means here what they're going to do, they will do some kind of, they use some kind of scalpel and they will cut the dead tissues, or what is that? They will remove the damaged tissues. They use some kind of sharp material. Okay, it's kind of a step which involves in the excisional treatment. Okay, excisional treatment it will be involved, where I use some scissor, scalp, and curate to remove the old tissue and damaged tissue. If I go for non-selective mechanical, which means non-excisional method, like scrubbing, brushing, irrigation, if I do that method, now I cannot use the integumentary system codes. I need to go for the medicine related code. That series is 97597, 97598 or 9760 code. Okay, so when the wound care is taken by scrubbing, irrigation, or by wet dry, I need to go for the 7 series. When the wound care is taken with the help of some sharp tool, some sharp excisional tool with a deep or some method, it goes little deeper. In that scenario, I need to go for the 11 series. Okay. Based on that, I have the two set of codes, one for the single wound care, the other one is the multiple wound care. Okay. Single wound care, very, very simple. The deep we need to calculate. The deeper it is, the deeper the wound care is, the more the damage will be there. Okay, so the deeper it is, the more the damage will be there. Okay, so the deeper it is, the more the damage will be there. Okay, so the deeper it is, the more the damage will be there. Okay, so the deeper it is, the more the damage will be there. Okay, so the deeper it is, the more the damage will be there. Okay, so the deeper it is, the more the damage will be there. Okay, so the deeper it is, the more the damage will be there. Okay, so the deeper it is, the more the damage will be there. Okay, so the deeper it is, the more the damage will be there. Okay, so the deeper it is, the more the damage will be there. Okay, so the deeper it is, the more the damage will be there. Okay, so the deeper it is, the more the damage will be there. Okay, so the deeper it is, the more the damage will be there. Okay, so the deeper it is, the more the damage will be there. Okay, so the deeper it is, the more the damage will be there. Okay, so the deeper it is, the more the damage will be there. Okay, so the deeper it is, the more the damage will be there. Okay, so the deeper it is, the more the damage the size we are going to take the code. Okay, say for example, the deep of the wound is like 20 centimeter. We have a separate code, okay, which is like 11042, which is supposed to be used. Followed by that, if we have the any other like say for example, the size is more, okay, single wound, the size is 30 square centimeter. In that scenario, I need to use a 20 square centimeter code. Followed by that, I need to go with the add-on code. So we have the set of add-on code 110452, 11047. Those are the add-on codes. Depending on the size, I'm going to use them. Okay, then multiple wound. So you may have the different multiple wounds, but I need to go to the deepest wound. I need to go to the deepest wound. I need to consider only the deepest wound, and that deepest wound need to be calculated, which means I need to add the deep, okay, of the same site, same tissue. Then I need to go for the separate code where I will be having the codes based on the centimeters, square centimeter. I will be using those codes. Okay, so here I will be giving you some of the examples. Okay, see here, different set of examples is there for the wound care. First one, debridement code not involving the subcutaneous tissue. Okay, here what they're doing, removal of devitalization tissues from the wound, selective debridement without anesthesia, wound assessment, topical application. Here I'm not using any scalp or something like that. In that scenario, I will just go with the 7 series, as simple as that. If the size is more, if first 20 square centimeter, we have one code. After the 20 square centimeter, we have add-on code. Okay, then next, if you see debridement code, involving in the subcutaneous tissue and deeper. Here, which level it is they are taking, till the muscle and fascia level. Okay, till the muscle and fascia level, I have one separate code, that is 11043 for 20 square meter. Then each 20 square meter, I will be using the add-on code, that is under involving the subcutaneous and the deeper. Next, if you see subcutaneous tissue, okay, till the subcutaneous tissue, it is a muscle and fascia. Next one is that till the subcutaneous tissue and muscle, fascia, epidermis, and the dermis. So from the, what is that? From the subcutaneous tissue, I am having the problem. I'm having the debridement. I'm doing the debridement. In this scenario, I have separate code, that is 11044 for that separate add-on code. Now, depending on the layer, okay, whether it is the epidermal layer or whether it is going for the subcutaneous level or whether it is going to the deep to the muscle. Okay, so in that form, if you see from the reverse order, 11042, 11043, and 11044. So subcutaneous tissue including epidermis and dermis, muscle tissues including epidermis and dermis and the subcutaneous, bone, subcutaneous tissue, muscle and fascia. Depending on the layers, we have the separate debridement code. Deeper, like subcutaneous level, muscle level, bone level. 3 different codes. For each, we have the separate add-on codes. Okay, that is what the entire structure tells us. Some example, 2 examples are provided here in the right corner. So now if you see 15 square centimeter subcutaneous tissue debridement from the right leg, 10 square meter subcutaneous tissue debridement from the left leg. Here, I do not worry about the anatomical structure. I need to worry about the depth. Both are subcutaneous level only, and size is 25 square centimeter. 15 plus 10, 25 square centimeter. Now, what is a layer? It is subcutaneous layer. What is the code for subcutaneous layer level for first 20 square meter? 11042. For each additional square, okay, I have the separate code, that is 11045. Next, if you see 10 square centimeter of muscle debridement from the one wound, 15 square centimeter of devitalization dermis and epidermis and dermis debridement from the separate wound. Okay, so 2 different wound, one deep to the muscle level, one more is there is no scalp is used, no straw. It is a non-excisional method they use. In that scenario, I'll be coding the 10 square centimeter of the muscle, because that code is 11043, only muscle level the wound layer is there. And the second is like I do not use any scalp for other wound. In this scenario, I'll go for the 97 series. Okay, for first 20 square centimeter, 97597. Okay, so this is a table which is going to tell how you're going to conclude the codes. First, if you see the first wound is there in the subcutaneous layer, muscle layer, and bone layer. Now I cannot consider the subcutaneous and muscle. I need to code only the bone level. 3 level of wound is there in the same anatomical area. Okay, say for example, foot. They are given example for the foot. There is a wound in the 20 square centimeter of wound in the subcutaneous layer of the foot, muscle 20 square centimeter, and in the bone 20 square centimeter. It is not necessarily to use 1142 or 1143. I am supposed to use 11044. Okay, that is the code I'm supposed to use. I need to go to the deepest level of the wound. Remember, deepest level of the wound. Now, next, same foot and leg and hand in the subcutaneous level. See there, where is the wound is there? Three places the wound is there. Foot, leg, and hand. Which level? All three are subcutaneous level. Now I need to add all these three. 10 plus 5 plus 10, 25. Then I need to code two codes. One is the subcutaneous level code 11042, followed by that add-on code 11045. Okay, then next, one wound is in the foot, the other wound is in the leg, the other wound is in the hand. Now, different anatomical site. Different anatomical site. In the first example, you saw in one anatomical site. In there, I have taken the deepest. Here, different anatomical site. I need to code separately. I need to use the codes separately. Subcutaneous layer, I have to code. Leg of the muscle, I need to code. Bone, I need to code separately. Yes, clear now, Buna? How the
Yes, sir.
we
Yes.
can just consider. So be careful. That is the reason I'm going little slower here so that you don't miss out anything. Okay, because if
Okay,
you
sir.
good with this integumentary, we are going to be good with all other terms. It is going to be very easy for us in the second series, third series, four and all. If you're well versed in the first series, remaining all is going to be very easy.
Okay.
Once the
So
class
likewise in lacerations we do add the length and we
we
do
go
see
further. We
the
are going
codes.
to see all
Ah,
those things. Okay, this entire class is today on the entire integumentary system. One by one, we are going to see. Okay, because
okay,
this
sir.
is the integumentary system is the one we have different concept. Okay, first we
Okay.
saw something related to the biopsy. Then we went for the different punch biopsies, all those things. Then we have entered into the what is it, foreign body removal. Then we enter into the INT, okay, incisional drainage removal.
Right.
Okay, then phenodonial cyst. Okay, then we have come to the wound care. Likewise, all the things we have different concepts. There we have
Yes.
based on the needle, based on the simple and complicated, separate codes. We were coding, right? This tangential biopsy, and we saw the hierarchy and all there. Here we are going to code based on the depth. This is a concept for the wound care. Other term we call it as a debridement. Next
Yes.
is right, very simple one, removal of skin tag. There are so many methods to remove the skin tag. Okay, like we have methods like chemical method is there, we have dry method is there, and we have what is that nitrogen, liquid nitrogen, use of liquid nitrogen is there, and we have the electrocurative method is there. So many methods are there in the removal of skin tag, but luckily in the coding we have only one set of code. Okay, removal of skin tag, generally straightforward medical procedure. Okay, directly they are going to remove. The method is going to be any method, but we have the only two set of code for first removal 11200. For each additional skin tag removal, we have the add-on code. As simple as that. Okay, they're going to cut and take that. That's it. Then, because it is a surgery, that is the reason they're going in that method. The next one is like shaving of the epidermal and dermal lesions. Okay, here shaving means, as I told previously, we were discussing on in tangential, we are discussing about the shaving removal where they used for the therapeutic method. But here it is quite different where they do the shaving the transverse method where they go for small incision, not in the outer layer they're going to do the small incision. They're going to cut both the good layer as well as the bad layer. Okay, they're going to remove the infected as well as the non-infected also. Based on that only we are going to take the codes for this epidermal and dermal lesions, which stands for 11300 and 11310 set of codes. Here how we are going to consider. Okay, there are different set of excisions are there. Okay, so first thing is like a skin lesion. Here what they're going to do, they're going to collect the benign lesion. Benign lesion means they may become the cancer tomorrow, but initially they're going to be originated means the place where it is developed. Okay, it can be a non-cancerous. Okay, especially when it comes for the excision of skin lesion. Okay, when we do the excision of skin lesion, depending on the anatomical site, we have the separate code. But I just cannot go and conclude the skin lesion directly. I may collect a small sample, okay, initially, okay, from the anatomical location. So, say for example, we'll take as a hand. In the hand, I'm going to collect. That is the first criteria. Second important, so to select the code factors, three factors, important factors required here. The second is like how much of diameter I'm cutting. That is a excision diameter. Very importantly, how much of diameter I'm going to cut. In that diameter, what is the infected one and what is the non-infected one. Infected one is, as usual, we call it as an infected or damaged cell, and non-infected cells, the non-infected tissue, we call it as margin. We call it as margin. That is the second foremost important criteria you need for the excision of skin lesion. The third is the pathology result. The third is pathology. Why we need pathology result? Because I'm going to do the diagnosis here. So initially I will take it as lesion. When I send for the pathology, that can become a benign or that can become the malignant also. Simply, since when I'm removing the tissue, it is a lesion, I cannot go with the lesion code. In the pathology report that is telling it is a malignant, then I need to go with the malignant codes only, because the excision codes are segregated based on the anatomical site. Simultaneously, it is segregated based on whether it is a lesion excision or benign excision or malignant excision. We have the different set of codes. So by the initial stage itself, I cannot conclude the code for the excision of the skin lesion. I may collect it as a lesion, but it can become the benign or it can become the malignant. After that result only, I can able to come to the conclusion. In the exam point of view, that will be directly given, but in the surgery report, we need to wait for the pathology report. Okay, we get the surgery report initially. After 1 or 2 days only, we will receive the pathology report. Those kind of report we have to hold for, or we have to wait for the pathology report, then only we have to code. Simply, I cannot code whatever the surgery is performed. Okay, on that basis, the next thing is like how I'm going to calculate the good cell and the bad tissue and good tissue. How I'm going to calculate the good tissue and the bad tissue. So that excised diameter. Okay, the excised diameter. It is very simple. It is going to be a calculation which is margin. Whatever the good cells they are removed, I need to do it into two. Okay, say for example, you can see the picture here. It says margin 2 centimeter, margin 2 centimeter, excised lesion is 1 centimeter. Okay, the melanoma cell is 1 centimeter. Okay, the excised diameter is equal to greatest diameter of the lesion plus 2 into narrowest margin used. Narrowest margin used, which means the narrowest margin. These are the two margins, not this side they're talking. Narrow. Narrow means they're talking about vertical side. Okay, this side and this narrow. So how narrow is cutting? Narrow means you remember the shape, right? Like eye shape. Can you see the one more picture here in the right side corner? That shape, that narrow only we need to calculate. Okay. So now I need to do a narrow margin into two. In that scenario, 2 centimeter plus 2 centimeter, it is going to become the 4 centimeter, and 1 centimeter of the melanoma, totally 5 centimeter. I need to take the code for the 5 centimeter based on the anatomical side. If you see one example I provided here, if a doctor removes 1 centimeter of cyst of the arm and takes 0.5 centimeter of the margin of the each side, ensure it along the total diameter of 2 centimeter square, which means 1 centimeter plus 0.5 plus 0.5 margin altogether, it will come 2 centimeter. Now the area is arm. The code for arm is like 11400. The correct code, the range is 11040. The correct code is 11042 is the correct code. 2 centimeter, the size. Okay, this is how we are going to calculate for the skin lesions, excision of skin lesion or benign or malignant. Depending on that, we have separate code. Here I just showed you how the calculation will be done. So to code excision of skin lesion or excision of malignant or excision of benign, we need three important criteria: anatomical location, second is like excised diameter, third is like the pathology result. All together, I'm going to code the codes for the excision of skin lesion section. And then some more examples I have given here to understand how the narrowed path will be there. Can you see here how the margins are calculated? 0.9 centimeter malignant and 3 centimeter, 3 centimeter. That narrow part they have taken. Okay, that outer side, the top side narrow part they have taken. And above also you can see 0.2 centimeter margin, 0.2 centimeter margin, totally 0.4 centimeter plus 2 centimeter of benign lesion. I have separate. So that will be 2.4. And for the both malignant, I have the code 11642. So, and same way we have the code for the excision of benign lesion also. Separate code will be there. And this is example. So this is an example code for 11423. That is a code which comes for the benign lesion of neck 1 centimeter by the 2 centimeter. Okay, so we have to check for anatomical site, which pathological result and what is the diameter and what is anatomical site. Based on that, we are going to arrive the codes. Some of the clinical guidelines. Okay, wait for the pathology. As I told, we need to wait for the pathology because the code sections may get changed. So we need to be very careful. Then simple closure is included. I don't want to go for the simple closure because when I do the excision, yes, definitely I'm going to cut and remove. In that scenario, I need to go for the closure. If it is a simple or one layer closure, if it is simple or one layer closure, I don't want to code them separately. I don't want to code them separately. I can code only the excision code. When it comes for the intermediate or complex repair, okay, that is a intermediate repair or complex repair. In that scenario, I should be going for the separate coding. I should use the excision code as an addition code. Okay, that is very, very important. And we may encounter with the modifier 59 if they're doing the multiple lesion removal. If they do for the multiple lesion removal, I should be going with the 59 modifier. Okay, so that is a key guidelines which we received for the 2026 for the excision of the skin lesion or benign or the malignant. Yes, clear so far? We'll see some two examples, very simple
Yes.
examples. Say a surgeon removes a 1.5 centimeter of sebaceous cyst from the patient's scalp. The nearest margin is 0.2. It's very simple. Into 2, 4, 1.5, altogether 1.9. In the scalp area, there is a code 11422. Then mole on the nose, uncertain behavior. We don't know what is the behavior here. There, at least they told benign cyst. Here they did not they address what type of behavior we have. Here 0.4 centimeter and mole in the tip of the nose with the 0.0 centimeter of the margin. Pathology reveals the benign. Then it is going to be the benign code only. 11441. That is a set of code for the face or nose between the 0.6 centimeter to 1.0 centimeter code. Okay, these are the some two examples where we have seen for the skin lesion excision. Sorry, excision of skin lesion. Then nails. Okay, here nails also we have the two set of codes. Okay, one is the trimming and debridement, that will be a routine care, and one more is a surgical procedure, which means avulsion and excision. If you see, trimming is nothing, maintaining your nails or your tissues around the nail, okay, which is also called as numula, or which is also called as hyponecium, and what is that, the proximal matrix. Okay, so based on that we have separate code. Where this is mostly performed means, if you see this leprosy patient or infected patient or patient who had got wound in their nail or broken nail, this kind of patients will be there. No, for them they have to maintain all those things. Okay, to keep the fungal control and infections in the control, they will be using this trimming and debridement method. Trimming, we have only one code 11709, whereas debridement based on the nails 1 to 5 nails 20, 6 or more nails, we have one code 721. Then again, if it is performed for the Medicare patient, the trimming is performed for the Medicare patient, we have a separate code Z0127. That is a guidance for the trimming and debridement, which is a routine care of nail. Then second is a surgical procedure, which is avulsions and the excisions. Here we have the set of code. If it is avulsion for the nail plate, partial or complete, simple or single, I have one code, that is 11730. For each additional nail plate, okay, especially it works on the nail plate, in that scenario, we have 11072 as an add-on code. Then excision done to the matrix level, and which excision nail, we have the separate code. So we need to use 11750 and 1165, separate code for the nail matrix and nail fold removal. Okay, and we need to go with the modifiers, finger modifiers. If it is done in the finger modifier, it is done in the toe modifiers. And if it is performed along with the endum procedure, because it is a small minor procedures, I need to use the 25 modifier. Distinct services, we can go with the 59 and excess modifier. Sometimes they may come up with the Medicare, routine Medicare, okay, which will be indicating the medical necessity. In that scenario, Q7, Q8, and Q9 modifier. Most often we don't use this Q7, Q8, and Q9. Okay, other modifier, there is high possibilities to use the codes. Okay, this is the codes related to the nails. Then I'm sorry, this is a repeated slide. I will skip this slide. That is a phenodolial cyst. Then next is like the questions related to the phenodolial, whether it is whether it is going to be the only the abscess removal, or they're going to remove the complete cyst. Okay, it is like just for a clarification I kept here. So if you see the question here, the physician exercised complex phenodolial cyst and closed the wound with the rhoboid flap. The flap closure included the procedure described by 11772. Excision of phenodolial cyst or sinus complicated and should code 110 14000. Adjacent tissue transfer rearrangement. Trunk defect 10 square centimeter be reported in addition to the 11770. So there is a question they are asking. They have done the complicated level of phenodolial cyst removal, and additionally they have done the tissue transfer. What we are supposed to do? Whether we need to code the tissue transfer plus the complicated phenodolial cyst, or we have to code only the adjacent tissue transfer alone. That is a clarification here. Okay, so here the flap closure is not included in the procedure of 1172, For the procedure described adjacent to the tissue transfer, 14000 should be reported separately in addition to the 11772. As simple as that. Okay, so both code both the phenolonyl cyst removal as well as the ATT. We'll be discussing about ATT and all. The slides are little misplaced. I forgot to replace the slides. So just I'm covering that here itself. Okay, then next is like one more a simple code, hormone pellets and Nexplanon implantation. Okay, when we come across this type of scenarios, okay, especially one is like a contraceptive birth control type of implantations, and one more is like pellets, okay, which will be providing the hormones, releasing of the hormones for the patient of menopause treatment, and for others stress and depressions. For that, they place some kind of pellet in our body. So we have separate code for that, that is 11976 and 980, depending on the type of pellet they're going to use. Same way we have the contraceptive control implants also. We have separate codes for that also. That is 11981, 82 and 83. It's very simple. Whatever the pellets or implant they're going to use, we are going to use these separate codes. Then coming for the next one, repair. Okay, otherwise we call it as a closures. Okay, we have the three type of wound closure, that is simple, intermediate and complex. To code the repair, what are the documentation required? First, we need to know what is the complexity, whether it is a simple or intermediate or complex. That is very, very important. Okay, then second is like which anatomical location. The second foremost important is what is the anatomical location. And the third is like what is the length of the wound. Depending on these three distinct criteria only, you can able to come to the conclusion for the repair or wound closure. Here, type of skin closures, sutures, adhesive strips, staples, and skin adhesives. These are the different type of skin closures. Okay, what are the closure methods? We can tell these are the different type of closure methods. That is surgical suture, surgical staples, and strip adhesives, and surgical glues and topical adhesives. Here, if the patient is using any adhesive strip, okay, skin adhesives, if he is going to use that, or if he is going to use the staples, okay, if anyone this one thing is going to use any adhesive strips or skin adhesives or staples he is going to use, I cannot code the integumentary system code. This wound closure will become the E&M code, that becomes the office visit. Okay, because it is very simple form. It is not even a closure. There is no closure is done. There is no layer closure is done. Just the outside, okay, above the epidermis, the skin is getting closed. In that scenario, I can use some staples or some adhesives I will be using. In that scenario, I'm not supposed to code the 11 series, or it's not supposed to code the integumentary series. I need to go with the E&M code. It may go for the complexity code. Okay, high complexity, high level code it may go, but I cannot use the 11 code. Okay, so as I told in the first point, the rule summing of the length. Okay, summing of the length means add together of length of the wound from the same complexity, and the same anatomical group. Do not add simple repair to the intermediate repair, which means how the length is calculated. How the length is calculated means same complexity of the wound only I need to calculate. I need to add up. I cannot use different complexity of the wound. Okay. If it is a simple means simple plus simple plus simple. Intermediate plus intermediate plus intermediate. Complex plus complex plus complex. That is how I need to add the length of the wound closure. Okay, that is very, very important. Then adhesive strip, as I told, when they're using the adhesive strip and all, it will go for the E&M codes. Then measurement, always document and code based on the centimeter. That is very, very important. Always by the centimeter, because the codes are assigned, the codes are constructed based on the centimeter only. If the doctor record in inches, convert to the centimeter. If the doctor records in the inches, convert that to the centimeter, as simple as that. Then other of the codes, list most complex repair as the primary procedure. Complex repair should be the primary procedure. That will be the sequencing. Okay. Sum of the length of the repair for each group of the anatomical site. Then simple repair, as I told, it is going to be a wound closure of a superficial level, which is like it involves in the epidermis and dermis level, possibly subcutaneous they're telling, but it will not go for the subcutaneous. Okay. Remember, simple repair, it is going to be epidermis and dermis. Okay, much process will not be involved here. Much process will not be involved here. Be careful in that. Then required only the single closure using the suture, staples, and tissue adhesive. Remember, they need to do the single closure. That is the major difference between the E&M code, using the E&M code, or simple, which means like intimately related repair code, which means if they need to mention very clearly one layer closure, single layer closure. After doing the closure only, they need to use suture, staples, and tissue. Simply they're telling suture, staples, and tissue means used, means I cannot just go with the simple repair code. Okay, remember that one point. Okay, then second is like included service. Yes, here local anesthesia is included. If they use any electrical or chemical curatives, categories, it is also included. We cannot bill separately. And the documentation clues, in the documentation, how it is going to be: single layer closure, superficial wound, minimal tissues involved, basic suturing and straightforward closure, not mentioning the deeper layer. Okay, these all are the documentations which you'll be able to see. Some clinical examples: minor cut or laceration with minimal depth, abrasions, small facial laceration, cut from the paper glass or minor trauma, post removal of wound closure after the simple lesion removal. Okay, these all are the some of the clinical example means which you see in the documentations. Okay, these are the simple repair will be there, so it should be mentioned as single layer closure. Okay, in the documentation, few cases they are considering the sutures, staples, tissues also, but the general guidelines is always go with the layer closure. This is how the documentation will be there. Then some example I provided here, very simple: 3 centimeter superficial cut in the forearm from the kitchen knife that is closed with a single row of the simple interpreted suture. The code is 12002. Directly, the code leads to the description of the code is simple repair of the superficial wound of scalp, neck, axilla, and external genitalia, trunk under extremities 2.6 centimeter to 7.5 centimeter. If it is given in inches, always convert to the centimeter. The second is intermediate layer, where it goes to the deeper to the subcutaneous tissue, but it will not go to the muscle. Maybe to the level of superficial fascia, but it will not go to the muscle. If it goes to the muscle, it becomes the complex. Okay, here intermediate repair. If you see the documentation clue, how the documentation will be there means layered closure. Layer closure is different, layered closure is different. Okay, be very, very careful. Then involving the subcutaneous tissue, removal of debris. Yes, the term debris, extensive cleansing, contaminated wound, and undermining of the tissues, closure of the deeper layers, moderate complex wounds. These all are going to comes under the terms for the intermediate repair. Okay, so single layer closure can still be coded as intermediate closure if the wound is heavily contaminated and requires extensive cleaning or removing of the particulate manner. Okay, here it is not about the layer also. By the layer, only layer they are not talking about. Yes, it goes for the simple. Along with the single layer closure, additional steps like a contamination wound cleaning, undermining of the tissue, or removing of the deep tissue, like that if they're going to talk. If they're going to talk, even though there is no multi-layered closure, or if there is no layered closure, only single layered closure is there also, we can consider for the intermediate. For the intermediate repair, it is not only based on the layer closure, it is based on the intermediate for the extensive cleaning or for the undermining or removal of the contamination. These all terms are very, very important. So we need to be a little careful. Along with that, it has to go to the level of subcutaneous tissue. One example I provided here, 4.0 deep laceration on the forehead, where the physician must suture the subcutaneous tissue first, then the skin with the separate layer. So two layered closure, multi-layered closure. Simply I will go with the excuse me, uh, intermediate repair. Then third is the complex repair. So by reading itself, you will come to know. By reading this itself, you will come to know. See the documentation. So goes beyond the layered closure, typically involves in the extensive undermining, stent, or the retention of the suture. Okay. The key requirements: it has a layered closure. It must involve at least one of the following: scar revision procedure, debridement of the traumatic laceration or avulsions, or extensive undermining of the tissue beyond typical intermediate repair, stent or retention sutures, creation of the limited defect for repair purpose, debridement of a complication lacerations or avulsions. These are the some of the key requirements for considering the complex. By seeing itself, we'll come to know whether it's a complex or intermediate. That much of clarity will be there. Only some place where intermediate and simple will be little confused. Okay. The documentation clue: complex repair, extensive reconstructive repair, scar revision, significant debridement, removal of devitalization tissue, then undermining, extensive undermining, undermining here, extensive undermining, retention, extensive contamination cleaning. They're only contamination cleaning, here extensive contamination cleaning, traumatic laceration, avulsion, flap and graft. This all it will take you to what? Take you to the complex repair. Here, if you see a jocked 5 centimeter laceration of on the cheek that requires extensive undermining of the skin to allow the edges to meet without tension, plus a layered closure. So here the main thing is like extensive undermining is one of the term. Based on that, I can use 13132 codes for the complex repair. Then comes the wound repair guidelines.
Sir,
Okay.
one small doubt, sir.
Yes.
For example, in documentation clause, if they given like removed, foreign body noted, foreign body founded, also should go with complex and intermediate, no, sir?
Complex and intermediate.
Mm.
Depending on the what anatomical site it is going on. Okay, see, when it comes for the
Okay, sir.
foreign body removal, till the subcutaneous layer, it is simple. After the
Okay, sir.
subcutaneous layer, it is going for the
Complex.
complex. Okay,
Okay, sir.
now if it is the thing is going to be, say for example, the foreign body is present in the dermis. Okay, but
Yes.
he is doing extensive complex, extensive contamination removal or extensive undermining he is doing. Okay, in that scenario, how many layer of closure he is doing? If he's doing single layer of closure, I can go with the intermediate. Okay, because they're doing the normal contamination removal or normal undermining of the tissue. That level only they are doing. Okay,
Okay.
that is also dermis level. In the dermis level, now whether I can go for the complex means I cannot go for the complex because two scenarios. One is there is no multi-layered closures is there,
Okay.
and the foreign body is present in the simple level only. So it is better to go with the simple with the intermediate. Now,
Okay.
if it is in the muscle level, if it is in the muscle level, now it come for the complex. Okay, the foreign body come for the complex. Now, whether I'm doing the and what is that contamination removal and extensive removal, in what level I'm doing, that is very very important. Okay, in that scenario, if I'm going to go with the extensive undermining, okay, and extensive contamination removals, in that scenario, yes, I can go for the complex. Okay, complicated with the complex also I can go. So that is the reason I provided this much of clue here. Why? Because it seems to be similar. One side layer will be there. Yes, based on the layer I can go. Other side, the treatment, whatever they're providing, whether they're doing normal reconstruction or whether they're doing extensive reconstruction or whether they're doing the contamination clearance or undermining for the normal cut, something like that, or for the traumatic related. For the traumatic related, they're doing the debridement, or traumatic related, they're doing the what is that, a repair. These are all things we need to verify. Then only we can able to come to the conclusion. Okay, on the foreign body, it is very easy, simple and complicated. We can go based on the what type of what layer it is foreign body is removed from. But when it comes for the repair, what type of layer he is closing and what are the steps he has taken to close the wound, whether
Okay.
debridement is done, whether the what is that undermining is done on the tissues, or whether he's removing the contamination. These all things we have to verify. Based on that, we have to come for the conclusion. Okay,
Okay, sir.
depending on the documentation. Mostly, if you see the complex, no, it will be very clear. You by seeing the documentation itself, you will decide you need the complex, because sometimes, like most of the complex, they will go with the flapping, grafting. This kind of terms will come. Okay. Again, in that scenario, when they're talking about flapping, grafting, and all, the code edits may, based on the edits, the code may change. Sometimes you may use only ATT, or sometimes you may use ATT plus complex, depending on the code, depending on the edit, that also will get changed. Okay.
Okay, sir.
Next is like the wound repair coding guidelines. So what are the guidelines we need to verify on? So first, as I told, simple complexity and what is that? A simple complexity and the same anatomical location, combine the length and report as a single code when you are using for the multiple wounds. Okay, different complexity or locations code separately with the 59 modifier if it is necessary. Multiple procedure reductions apply to the secondary procedures, which means like when they're coding the very complex one, it is not very mandatory to code the primary, like the simple or what is that, a simple repair or intermediate repair also, because the complex repair, when it is paying completely, we don't want to go for the secondary codes there. Okay, so these are the step. Determine the complexity, identify the anatomical location, and measure the wound length. That is very mandatory for the wound repair. Then some of the examples I provided here. So first, if you see a patient present with a 3.0 centimeter jagged laceration in the forehead of 5 centimeter of laceration of right arm. The physician performs layered closure of the forehead and a simple one layered closure. So now what type of layer closure this is? What type of layer closure? Simple or intermediate or complex? Yes, try to answer that. If you know that, that is sufficient. You don't want the code, what type of layer closure it is? Hello?
Sorry, sir, my mic is on mute.
Yes.
Sorry.
What type of layer closure here it is?
Intermediate, sir.
Here it is intermediate, you're sure? It is a
Yes, sir.
simple one layered closure.
But here, layered closure and there is a simple one layer closure on the arm. That is two different sides. So we can't add those. Right, sir.
Okay.
Um,
So you will be coding the two codes, as you said.
yes, sir.
You will be coding the intermediate as well as the simple
Simple
one.
one. 1200 to simple.
Yes.
Sir.
Then a patient present with a deep 5 centimeter laceration of the dorsal surface of the hand. During the repair, the physician needs a severe extensor tendon, which
And
is she repairs. She then perform a complex skin closure over the site. Here,
we go with complex, sir. Why? Because that tendon visible is there. So we
okay,
go with the complex one.
okay. So your understanding is right. Here, we have the separate code for tendon repair. Okay.
Okay.
So when the tendon repair is done, other closures are not considered as a primary code. Okay. So
Okay.
remember, when they're doing any procedures, okay, when they're doing any procedures, if there is a complex procedure, if they're doing any complex procedure, the other smaller procedure will not be, or minimal procedure will not be considered because that will be bundled. Okay. For your
Okay.
better understanding, I'll give one example. Say, for example, they're doing the knee arthroplasty. Okay. When they're
Okay.
performing the knee arthroplasty, it is a complex procedure. Okay. They may perform in different type. It may be lateral approach, or it may be medial approach, or it may be unicompartmental, or it may be total knee arthroplasty, or it may be partial knee arthroplasty, anything. So the replacement can be done with some kind of plate, rods, anything, the cage, something, anything they may use. This is a complex repair. When they wanted to do that, simply they may go for different type also, different approaches also, which I can tell, like open approach or arthroscopic approach. Either arthroscopic approach they may perform, or they may perform for the open approach. During that scenario, when they do, say for example, when they do open approach, they have to cut and open. When they cut and
Yes.
open, during that time, they may be able to see other problems like tenoitis, or there is a repair, there is a tear in the meniscus. Okay, this kind of things they will be able to see, but the ultimate aim to perform the orthoplasty only. Okay, they're going to do the replacement. When they're going to replacement, simultaneously they will do the, say, tenovectomy or a mastectomy they may do. Now vasectomy we have the separate code, tenovectomy also we have separate code. Okay, but we cannot code along with the orthoplasty because orthoplasty is the major procedure. While doing that procedure, for that procedure, I may do these additional things. Okay, this cutting, attaching. Okay, these all things I cannot consider as a separate code. That will be included in the major procedure only. Here, yes, they're doing the laser closure. For what they're doing the laser closure means extensor tendon. For the extension tendon, they're doing the laser closure, which will take you to the 2 series code, which is 2610.
Oh, yes. Yes.
Okay, you understanding?
Yes. Yes, sir. Yes, sir.
So there, what our misconception here, what is our more practice here is like, by just seeing the term, okay, repair is there, complex is there, intermediate is there. No, don't go like that. When I
Okay.
do the major procedure, when I do a major procedure, along with that, I may do the debridement. That is the reason from the beginning we are seeing biopsy will be included, debridement will be included, wound care will be included, okay, and
Okay.
removing of the foreign body also will be included. This all will be included when they're doing a major procedure. Okay, remember that. See, when they're coming for fixation of, when they're coming for the fixation of fracture or some dislocations by using open approach or by using the arthroscopic approach, percutaneous approach, different approaches are there. Close reduction approach, some approach they may come. That to like open fracture and all, you will have the foreign body inside. Now I have to remove the foreign body. I have to drain the whatever the fluid present inside. Then I have to do the closure. Simultaneously, I have to do the repair also. Correct?
Yes,
Repair
sir.
means I need to do the fixation. They're doing the fixation. For doing the fixation for that fracture patient, What are the problems will be there? Once open wound is there, there will be infection. There will be some debris, which means a foreign body will be there inside. Okay, then I need to put the sutures. Okay, I need to do the closure. Now these all we studied separate guidelines, correct? We have
Yes.
studied the guidelines for the removing the wound care also. We already studied the separate guidelines. We have studied the guidelines for foreign body removal. We have studied the guidelines for the incision and drainage. Okay, then we have studied the guidelines for repair also. But ultimately what he is doing along with these four minor procedures, he is doing the fixation. When I'm coding the fixation, I don't want to do all those things. Okay,
Yes.
only in the scenarios, in the rare scenarios, when they do it in the different anatomical area, I may code along with that. Not in the same incision, not in the same open place. Okay. And
Okay.
during this complex repairs also, this flaps and the ATT, which means adjacent tissue transfers, criteria will get changed because he is doing one more cutting for fixing this wound, for closing this wound. Sorry, for closing this wound or fixing this wound, is cutting from some good place and bringing to the bad place. In that scenario, I need to code for that place where he has initiated the cutting and the place where he has fixed also. We call it as primary defect and secondary defect. In that scenario also, we need to code only the major procedure. There the major procedure may become, the ATT may become the major procedure. Okay. Say for example, they're going to do the excision. When they do the excision to the deep level, okay, there will be a very open area. To cover that open area, they may do the tissue transfer. They may take some tissue and cut and put it here. So that I cannot code the excision one time and tissue transfer one time, because tissue transfer as the guideline saying that primary defect area plus secondary defect area. Okay, adding both only I have the ATT code. Again, I cannot code the primary defect area one more time. Understanding the logic there? Excision is the primary defect area. When I'm collecting some tissue from the second area, that will become the secondary defect. But what is the ATT code is designed? What is the guideline says? Primary plus secondary. So I'm coding for the primary plus secondary. I'm adding primary damaged area and secondary damaged area and coding a separate code. Again, I don't want to code the excision code separately. Okay, I will explain you that also in ATT when we are discussing. Third one is like, a patient has 10 centimeter of wound on the trunk. Physician spends 20 minutes performing the extensive debridement of the necrotic skin and subcutaneous tissue that is not associated with the repair. In the separate area, he performs 4 centimeter of simple repair of the scalp and 6 centimeter of the simple repair of the neck. So here what and all he is doing? He is doing one side, he is doing the debridement one side in the subcutaneous layer level that is not associated with the repair. Remember, I'm not going to use the repair code here. Here I'm going to use the debridement code. Okay. So
Yes.
you just cannot keep in the mind repair. For repair, debridement is one criteria. Yes. For
Yeah.
repair, debridement is one criteria. But here he's telling very clearly he's not doing the repair. Keep that in the mind. Then second thing is like, separate area, he performs 4 centimeter simple repair
Simple repair.
on the scalp and 6 centimeter simple repair on the neck. And if I add, it becomes the 10 centimeter. Now, what are the codes I need to take? Simple repair code I have to take. Debridement code I have to take. Okay.
Yes.
Debridement, how we calculate? First 20 square centimeter. Correct? You remember?
Yes, sir.
11042, 11044, 43 debridement codes.
Yes.
Depending on the layer. If subcutaneous means 42, muscle means 43, and if it is bone means 44.
4, 5.
Okay, those are the codes. Now here, based on the two codes, one is like 1-2 series, the other one is the debridement code. So same,
Yes.
simple repair code, 7 to 12 centimeter, scalp, neck, axilla, trunk, and extremity. Here, scalp and the neck is there, same code is sufficient. I'm going to add it. Okay. Say for
Yes.
example, if I told 6 centimeter simple repair in some other area, say for example, stomach, if you are told, in that scenario, I need to code a separate code, one more code for the simple repair. Then
Yes.
next code is like, a patient has a massive jagged 50 centimeter wound on the trunk. The physician performs extensive debridement of the 25 square centimeter. Okay, that some error is there. Ignore that. 25 square centimeter of subcutaneous tissue and skin to remove the dead tissue. Okay, so and skin to remove the dead tissue. After debridement, the physician is too wide for the standard closure and performs the complex repair using the retention suture. It is self-explanatory. It is a complex repair only, right? Because he is using complex repair for the using retention suture. You remember, retention suture is one of the criteria for the complex repair. Okay, here I will be coding the two set of code because the size is 25 centimeter. I may get the two ports. So one is 13103 complex repair, and each 5 centimeter I'm using the complex repair code, that is 13102 into 3 times. Okay. So this is how we are going to take the repair codes. The next important topic is ATT, adjacent tissue transfer. We otherwise call it as local flap. Otherwise we call it as local.
Local flap.
Okay, so usually it is performed, say for example, there are different methods are there like advanced flap, rotative flap, transition flap, all these things are there, but the flap calculations will be different. Okay, they completely, they'll be calculating the defect area and they'll be using the codes. We don't code based on the type of flap they performed. We code based on the how much of the defect it is there. Okay, that is the first thing. So otherwise we call it as a local flap because there are other types of flap also is there. So to keep that in the mind, I'm telling the local flap. What is adjacent tissue transfer? What they basically do? It's like a simple skin grafting, we can tell. Okay, simple skin grafting. Grafting is something I collect the tissue, okay, a healthy tissue from different area, okay, different anatomical site. Okay, but this adjacent tissue transfer means, say for example, I have a wound in my cheek, which is very deeper. Now, I will not collect some sample from the other part like leg or hand or something like neck. I will cut some good layer near to the cheek and I will bend it and I will attach it. Okay, I will bend it and attach it so that the damaged, the second defect area also will grow and the primary defect area also will grow faster. Otherwise, if I'm keeping the deeper wound for a long time, what happens? I will be ending up with the infections. I will be ending up with the infections. Okay, if I have the enough blood supply, if I have enough arteries and veins there, automatically my wound will get repaired very faster. So local flap involves in relocating the flap of LD skin. Remember, skin grafting always involves in the tissue level, sometimes muscle level also, sometimes bone level also. But when it comes for the flap level, that is a it is a initial level of grafting, we can tell. Okay, so skin level it will involve under the skin tissue from the immediate donor. Immediate donor means nearby. That is what they're telling, nearby, immediate donor site to the nearby wound. The flap remains attached to its blood supply. Unlike a simple skin grafting, the flap remains partially attached to the its original blood supply. That is what the big difference. Okay, I'm not cutting from one place to attaching to other place. I'm cutting from nearby place and attaching so that the blood supply will not be disconnected. It will be keep on applied. The wound will heal faster. Okay, these are the different types. Then we'll see how we are going to calculate. Very simple. Total area, that is square centimeter, is equal to primary defect plus the secondary defect. Primary defect from the secondary defect. What is primary defect? The original wound or the hole left immediately after the lesion is excised. Lesion or malignant benign after excised the first area. Okay, that is a first defect area. That is a primary defect. Secondary defect, nearby the donor site is there. No, that is called secondary defect. See the picture here. 1 centimeter plus 2.03 centimeter. Primary defect plus the secondary defect, which means 1 centimeter plus 2 centimeter, totally 3 centimeter. My code should be taken for the T is the 3 centimeter square. As simple as that. That is the guidelines for ATT. Okay, remember this. Try to remember this guidelines. Debridement square centimeter. Removal of excision of the lesion. Good margin place, infected place. Then ATT. It is always completed with the primary defect plus the secondary defect. Okay, that is the reason I'm going with this slow, because this all needs some guidelines. Okay, then bundle rules. The bundle rules, ATT codes include the excision of the lesion. This is what I'm talking about. ATT code includes the excision of the lesion, that is benign lesion code, malignant code, lesion code. Okay, even though I remove the malignant, even though I remove the lesion, that area has the halo space. I agree with that. Okay, halo space. I have done the excision, but when I'm doing adjacent tissue transfer, I'm taking a good tissue from one place and closing the other place. In that scenario, I don't want to code the excision separately. That is always bundled with the ATT, adjacent tissue transfer. Remember that. Then no simple undermining. Simple pulling of the edges of wound together to the close it not qualify as the ATT. You remember for stitching and all, when you have the opening, they will attach the skin and they will do the stitching. Okay, that simply they will clean it outside and they will do the stitching. That is not adjacent tissue transfer. Adjacent tissue transfer means it will be having the separate procedure where they will cut the adjacent tissue, adjacent donor tissue, and replace the repair, which means it will go for the complex repair level. Okay, it will go for the complex repair rubber. So when I do the adjacent tissue transfer, remember, I cannot apply it for the simple wound or simple wound care or simple wound closure. I need to apply that for complex wound closure. Then multiple flap. If multiple flaps are used to the closing a single defect, then they are not coded individually. You sum the total area of the flap used for the one defect. Okay, what we are supposed to do here, there is no formula for tertiary defect or quadric defect. Here only the formula for primary defect plus secondary defect. So how many secondary defect also? Okay, I can take from the right side some tissue, top side some tissue and close. I need to add it together. All the secondary defects should be added together and add with the primary defect. Okay, even it is a multiple flap. Able to understand how it is going?
Yes, sir.
So this is how we need to go the ATT. One example I provided. The surgeon exercised 2 centimeter malignant lesion of the patient cheek. After excision, the result wound, the primary defect is 3 centimeter into 3 centimeter, 9 square centimeter. And because they're done here, excision is done. Excision is done means we need both good and bad. Okay, that is why they are given all together 9 square centimeter. Only if they told excision of malignant lesion means 2 centimeter means where is the margin? That will be the next question. Be careful. That is what when they talk excision of lesion means our rule, we need margin under the damage. Both should be there. Only damage is given means I cannot conclude the what is the size of the excision. That is very, very important, very, very critical. Simply, I cannot think, okay, 2 centimeter, fine. I cannot go like that. Okay. Here, primary defect is like 9 centimeter, which means 3 into 3 centimeter. They're adding it as a 9 centimeter. Okay. Plus, to close the surgeon creates a flap secondary defect that is 2 into 4. Okay. That is 2 centimeter into 4, which is going to be the 8 square centimeter. Okay. Now, 8 plus 9, it is going to be 17 centimeter. We have the separate code. For the code range of cheek falls under 14040, 14041 series, 10 square meters, 10 square centimeter to 30 square centimeter. We have one code, which is 14041 will be the code. Okay. So that is very, very important. And again, I cannot put the excision here separately. So must remember rules. Code include excision and flap repair. Do not report excision code separately. Simple undermining is not equal to secondary defect. Okay, simple undermining is not equal to secondary defect. Skin grafting for secondary defect are separate. Skin grafting of secondary defect are separate. Okay, so that will be considered as a separate code. Then flap. This is one more flap. Okay, so what you've seen is a local flap, that adjacent tissue transfer. And in this flap, which you will encounter two more different flap, that is pedicle flap, and one more is mycocutaneous, otherwise faciocutaneous flap. Okay, here in medical coding, flap differs from the grafting. Flap differs from the grafting. Okay, because flap maintain its own blood supply through the pedicle or the vessels, whereas grafting is completely served from its original source. Okay, so why we have studied adjacent flap separately means because the entire methodology is different. Under the flap only, the adjacent tissue transfer also will come, but the entire methodology for that is going to be little different. Here we have two set of flap. One is pedicle flap and is a muscle flap. If you see the pedicle flap, we have from 155702 to 155731 are more complex. This tissue often tube or transfer in stage to ensure blood supply remains viable while moving to more or distinct site. Okay, this is very quite interesting. You can see the picture, right side one picture, nose picture I given, no, that person. See, that is a pedicle flap. What they're doing here is like he is having wound in the nose. There's a big hole in the nose. Now, I cannot collect some tissue from the cheek or forehead. Okay, I cannot do the adjacent tissue transfer. I cannot do the local flap. I cannot do. Why? Because I need so much of tissues here. Now, what I do, I'm taking some tissue from my chest. Okay, I'm taking some tissue from chest. I'm connecting to my neck, which means the blood supply will be now connected from the chest tissue to the neck tissue. Now, the blood supply is not disconnected. It is a stage where it ensures the blood is getting supplied, no damages will be there. Now, once the chest is okay, they will cut from the chest and they will cut from the chest and they will connect that area to the nose. Can you see that? From
Yes.
the bottom, it will be connected. Now, from the neck, the blood supply will be there. Blood supply will be there till the nose. Okay. Once that is developed, they will cut it in the nose. They will cut the tissue. Between tissue is there, no, the connection is there, no, they will cut it. Now, neck also will be get healed. and nose also will be getting healed. Okay, that is a
Yes.
stage wise stages of stages of transfer will happen to ensure blood supply is there. Okay, that type of flapping is called pedicle flapping. We have a separate code 155702 15731. Depending on the complexity, depending on the tissue transfer, depending on the size of the tissue transfer, we have separate code. Okay, depending on the anatomical site also we have separate code. Then next is like muscle or mycocutaneous or fasciocutaneous flap. This is something you can see in the hand, right? They will cut from some separate place and they will put it in this area. Okay, they are collected from the stomach. You can see the D picture. From that, they taken the tissue and they kept it in the hand where they have done the fracture fixation in that particular area. Okay, here it is a heavy duty flap. It has a separate series like 15732, 15738 used to fill the deep holes or provided bulk. They involving the moving an entire muscle along with the overlying skin and the blood vessel. Like they are completely they're taking everything like including the blood vessels and everything they're taking and moving there to make sure that is happening properly. We have separate codes for that 15734, 15736, and 15738 depending on the anatomical side. This is what the flap. In the flap, we can tell it like three type of flap: local flap, pedicle flap, and the mycutaneous or fasciocutaneous flap. Okay, where ATT has a separate calculation like primary and secondary defect. But when it comes for the pedicle and mycutaneous flap, there is also we consider the size and we consider the anatomical side separately. Okay, then coming for one more set of flap, that is delaying of the flap. Okay, here see, can you see the picture delaying? It is like two places he is having the wound. One is on the front side or anterior side of his foot, and in the behind the calcaneal side of his foot. What they basically do here means delayed flapping means they will create a flap in the good area. Okay, and they will make sure that flap is growing properly. Okay, and it will be done in two stages, and the flap timing will be 10 to 14 days. Okay, see, the method of delaying flap involves incision of border of the flap with or without partial subcutaneous evaluation and leaving it to the in situ for during the duration of time, usually 10 to 14 days, to improve the blood supply, and the stage 2 process will be continued. Okay, this is a two-stage process will be continued. So first what they will do, they will cut the outer layer to the subcutaneous level. They will cut. Now once it is cut, the wound will be get healed. Now the tissue will be there. No, whatever the tissue they have cut, they will not cut complete. They will keep it there only. Okay. Once it is grown normally, once it is developed normally, they will cut the tissue and put it in the defect area. Okay. And in defect area, again they will leave for some days. They will leave for some days. Once it is grown properly, then they will bring it to the second stage, which means other area they will bring it. Okay. So first they will cut from one area, stage 1, they will cut it and put it in the stage 2. You can see the picture. Okay. Now once it is developed, once it is grown, from there you will cut and put it in the third area. Okay. That is how the two stages of process happens with the delayed flapping. Mainly it will be done for the patients like diabetes patient. See, diabetes patients and all, I cannot take the risk of cutting two different area and attaching it, because if I cut in two area, now becomes 4 area defect. Already is having 2 area defect. If I'm cutting 2 times there and there, so if I'm doing one time cutting also, one time which means a primary defect also, so secondary defect if I'm going to do means I cannot cut and place it 2 places, the infection may increase. That is a diabetic patient's problem. Okay, like smoking people, diabetic people, that is a big problem. So I need to wait for some time. Once it is proper, then only I will cut from there and I will put it in the one more area. Even that cutting, it is like completely is going to cut. Can you see that how the cut is performed? They will attach, the attachment will be there. Then you will bring it here. Okay, that is what a delayed flap. We have the separate set of code for this as well. That is 156002 15630. Okay, the next foremost important criteria is important topic is graft. Okay, so graft, we have two set of graft. One is STSG and one more is FTSG. STSG split thickness skin graft and FTSG full thickness skin graft. Nothing. They may cut from the epidermis layer to a part of the dermis layer for the grafting. The other one is like epidermis plus full thickness dermis they may do. Okay, depending on that only, we have the two set of code, and depending on the size, okay, and depending on the location, we need to arrive the codes. So split thickness grafting or full thickness grafting. Split thickness grafting till the dermis, where full thickness grafting, complete dermis they may take. They may go partially for the topper layer of the subcutaneous, few cases, but full thickness means till the dermis layer. So size. So first 20 square centimeter or lesser, we have one set of code. And more first 20 square centimeter less for the forehead cheek. And same way we have for the nose, ear, and eyelids. So the grafting will be done based on the two type. Okay, that is what then the grafting. And if you see, additionally, we may encounter type of grafting. Okay, based on the type of grafting, also we have the code. You can see in the table. Autograft, we have the set of code. Then skin substitute if they're using. Okay, for that we have the separate code. And when it comes for the allograft and xenograft, we have the separate set of codes. Okay, remember that. Okay, based on that only we are going to arrive the codes. The 2026 guidelines for the skin grafting. Okay, so Medicare and many private payers have tightened the rules for skin substitute grafting, which means like 1572712, 1572778. So which is like a skin substitute graft. We should be very careful. Okay, that is a separate code is there where they may use the biological or synthetic materials to perform the closures. Okay, that is what skin substitute graft will be performed for. Then documentation failing. You must document at least 4 weeks of standard wound care. Yes, very, very important. I just cannot simply do the grafting. I would have tried some methods, especially this wound care method for closing the particular damaged area or particular infected area. I need to go with some wound care. If wound care is failure only, I need to go for the grafting. Okay, that is very, very critical. Then, in episode of the care, covering generally limited to 8 total application per 12 to 14 weeks of episodes of care. So when it comes for the caring, okay, so in the coverage which means the grafting coverage it is. Okay, so how long the time will be covered? It is like 8 weeks to 12 weeks to 16 weeks. After doing the grafting, I will be coming for continuous follow-up. I will not pay any extra money because the grafting may go for the infection. To ensure I'm not free with the infection, I need to give the complete follow-up. So for that, it will be covered for 12 to 16 weeks of episodes of period. Then, in case use of KX modifier to at least the application is medically necessary, if we exceed 4 applications. Okay, so sometimes when you're coming for the fourth time or fifth time, it is always better to use KX modifier. More than 4 times, it is always better to use the KX modifier because it is the modifier will indicate that this procedure is medically important. Okay, for indicating that only we are using KX modifier, especially in the grafting, they can be used. Then overall guidelines. Okay, this is something it will give you the overall picture. Okay, so like till there from the top to bottom we have seen excision, biopsy, repair, everything we have seen. No, for that is I included everything. Okay, see first if you see excision with the simple repair, always code the excision. Excision with the simple repair, we have to code the excision. Now excision with the intermediate repair, code both. Excision with the complex repair, code both. Okay, so this is what the criteria we need to follow. Then biopsy with excision, it's a simple. See, just imagine, logically remember, simple and biopsy, almost upper layer only they have done. In that scenario, it is better to code the excision itself. I don't want to give the preference for the simple repair or biopsy. Okay. Otherwise, intermediate, complex and all, they're going into the deep till the muscle layer they're going. In that scenario, I need to code both. Okay, that is the key logic you can keep. Then excision with surgical grafting, yes, code both. Surgical grafting, excision with surgical grafting means they do some grafting separately. That time I need to code both. Excision with the ATT, we already seen this, code only the ATT. Okay, as simple as that. Clear? So
Yes.
far, what are we are seeing? Okay, next one is burn. Okay, burn, it can be happen because of anything. It can be a chemical burn, heat burn, sunlight burn, or any other radiation burn. It can be any type of burn. Now, this burn has the 6 different degrees, okay, which is like first degree, second, third, fourth, fifth, and sixth. First is like only to the epidermis layer, second is like dermis layer, third is like that, what is that, to the subcutaneous layer, third it will go for the fat and muscles, so fourth it will go for the fat layer, then fifth is like muscle, sixth is for the bone. These are the different degrees of burn. Here, how we are going to take the burn codes? How we are going to consider the burn codes? We have the 2 set of codes. One is small or moderate burn. The other one is a severe or systemic burn. Small and moderate burn, it will be like till the subcutaneous layer, it will be maybe maximum to the dermis layer. Okay, so where we need a little debridement, little dressing, Okay, and little anesthesia will be provided for that. Okay, so which is a very minor level it is. Okay, very moderate or small level burn it will be. It may go for the epidermis or dermis or to the subcutaneous. It can be superficial or partial or full thickness. Okay, all this we have a set of code, that is 16000 to 16036, based on the degree of the burn. Based on the degree of the burn, we have the separate code. There is one more set of codes. Okay, that is systemic code. It will comes under your department, critical care. Okay, so which is not the ED also, it will go for the critical care, which is 99291 and 9922, 99292, because critical care is highly payable. ED and critical cares are very highly payable. Okay, so two set of burn. If it is small or moderate, go with the 16 series code. If it is a systemic burn till the organ failures it is going means, please go with the critical care codes. Okay, now we are going to discuss on the how I'm going to calculate the small or moderate burn. How I'm going to take the codes between 16000 to 1636. Okay, there are two methods. The first method is rule of 9. Rule of 9 means, see the babies here. Okay, baby and adult. So extremity 9 percentage, head 9 percentage, hand 9 percentage, okay, upper extremity 9 percentage, lower extremity it is little lengther 18 percentage, 9 plus 9. And if you see front and back 9. Only in the genital area 1 percentage. Okay, like that, in which area, which is also called total body surface. Okay, which is also called total body surface. Depending on the total body surface percentage, we are going to arrive the codes. Okay, we are going to arrive the codes. Okay, what treatment, like burn treatment, what till where the burn treatment is provided. Okay, the first rule is rule of 9. Based on the percentage we are going to take. This is one method. The second method, if based on the first method, I have given some example with the code. So 16000 initial first degree burn, and 16020 small, lesser than 5 percentage of the burn. Then medium 5 percentage to 10 percentage of the burn, and 30 it is going to be more than 10 percentage of the burn. Depending on the burn, we have the percentage of the total area, total body surface of the burn. We have the separate code. Okay, here if you see debridement and exorectomy. Debridement means the codes include the debridement and dressing changes. Do not double code the simple dressing changes if you're already using these codes. Okay, what I'm trying to tell, so we don't want to go separate code for a debridement code. You remember 11040 codes, don't code it, because in the 16 series itself the debridements are included. Okay, that is what they're trying to tell. But what is extractomy? Extractomy means when you get a burn, no, you will, the accumulation of pressure will be there. Okay, I'm not sure how many people you have seen like that. If something, if you, we can consider like this. When you get a, what is it? When you keep your finger in the fire, some kind of pain you will feel. After that pain, what happens? Some kind of formation will be there. White pus formation will be there after 1 or 2 days, right? 1 or 2 days you will see that. Okay, that will become a pressure inside. It will not get yield, it will get infected. Okay, to release that we do something is called extractomy, which means incision of the burn crust. Incision of the burn crust is called extractomy. Incision of burn crust to relieve that pressure. It will become like a white formation, patchy formation after the burn. I'm not sure like how many times we have seen or encountered that. That's something like you need to put an incision, you have to release that. Okay, based on that we have one code, that is a code for, what is that? That is a code of 1603 for
1606.
incision. The next code is for, sorry, the initial code. Okay, where is the code? Okay, here is it.
Yes.
16035 for initial incision, then 1606 for the each additional incision. Okay, then we have one more method. One more method is like Ludt-Brownder classification. This is also a total body surface calculation only. What is the difference means, he has given the table based on your age, based on the anatomical area. Okay, he has given the separate table based on the anatomical area and the age. Where there I have only for the adult, rule of 9, I have only for the adult, as well as I have for the child. There only percentage is given. Say for example, everybody is not going to burn with the entire extremity or entire trunk area or entire leg, right? It is not going to be the possible. They may have the fire in their finger, or they may have the fire in their forearm or in the elbow, like that they may have. In the particular area, they may have the burn. Okay, so to make that simplified, if it is entire extremity means I can go for a rule of 9. The codes are going to be the same. In the entire extremity, any one part, okay, any one particular area. In that scenario, okay, I can go with the age and the body portion to conclude what is the percentage of the degree burn. See here, head means first year birth 19, where it come for adult 7 percentage. So by keeping these calculations, I will be able to arrive the code. By using this method, I will be able to come to the conclusion whether it is a 5 lesser than 5 percentage, between the 5 to 10 percentage, or more than 10 percentage of the total body surface burn treated. Okay, so based on that, we have some of the guidelines, important guidelines. Okay, that is burn treatment codes are uh, used with the active treatment is performed, like example debridement, degree dressing, burn cure. These all are very, very mandatory. Okay, so these are the active treatment indication. So if that is there only, I can use the burn related code. Second, do not code simple dressing changes if it is a part of the E&M services. So when they are performed along with the E&M services, which is like simple procedure, do not code separately. Burn codes depend on the largest burn area. Okay, I need to consider based on the largest burn, not the smallest burn. Burn on the different body site can be combined with the calculating total body surface area. Okay, different area of the burn is there means I need to add up all together, then I need to consider. Okay, that is very, very important. If say for example, 3-degree burn in wrist, right wrist and left wrist, and 6-degree burn in forearm, and right forearm and left forearm. Now I need to consider 6-degree burn only, not the 3-degree burn. I need to consider the 60-degree burn. That is a largest degree burn are treated, which is the largest burn is treated, that I need to be considered. Okay, size is very, very important. Burn depth is very, very important. There are multiple site means I need to combine based on the table. I can go with the rule of 9, otherwise I can go with the burners table. Any one I can follow. Then next one is like some of the important guidelines here. Those are surgical preparation and skin grafting of the burn wound. Okay. So here we have first criteria, first set of criteria, like first set of guidelines for code 15002 to 15005, describing the burn and the wound preparation by incision or excision release of the scar contracture, which results in the open wound requiring the skin grafting. So what I'm coding here, I'm coding the skin grafting more than the burn. Okay, because the burn is treated with the skin grafting, that I need to code. Then surgical preparation of 15002 and 15005 is a skin replacement surgery. Describes the initial service related to the preparing of cleaning and viable wound surface, placement of autograft flap or skin substitute graft, or a negative pressure wound therapy with a tangential excision. Multiple layer burn tissues are removed, and from the until healthy tissues exposure, the wound may be excised down to the fascia or the muscle tissue. So whatever the methods, whatever the process is going to do for the replacement of tissue and the removal of burn tissues, okay, we need to end up with the 15002 and 15005. These all are surgical preparation, and the codes goes with the skin grafting code only. Then tangential excision of the burn is reported using the appropriate surgical code depending on anatomical site. Dressing is included in the excision code. Subsequent dressing changes are reported with E&M codes. Okay, so here, so the what type of dressing is doing for to the simple level is doing means we will be coding the simple level code along with the E&M. But here, when they're doing appropriate excision burning complete process for the surgical preparation, I will be going with the same 15002 codes. If it is a subsequent means, second time is going to come for the same treatment excision of the burn, subsequent dressing, I need to go with the E&M. I cannot consider the 1500 or 15005 series code. Then coding the series 16001636 is reporting the treatment of burn wound do not requiring the skin grafting. When the skin grafting is not performed only, I will be using the 16000 or 16036 codes. Okay, that is what the concept on the burn as well. Okay, so this is what entirely for the integumentary system. Okay, so we have completed with the integumentary system. Okay, so if
Okay,
any
sir.
other topic, simple topics is there, I will be able to cover. No, no, no. I think we have one more topic also. Just a minute.
Okay, sir.
These are examples for the questions what the code will be taking for the first degree burn in the arm. Then 15 percentage of the burn is there means what are the codes we have to consider. Okay, so depending on the percentage of the burn, we have the different set of codes. Some examples I have provided here. Okay, 5 percentage, 15 percentage, and this all percentage will be able to calculate based on the table which he has provided. Okay. Then
Okay.
next is like some scenarios also I added up here, like what we have seen for the simple same way. If local care it is provided means I'll be ending up with the burn core. Okay, because here they provided for the debridement of blister and dressing is performed in the and 9 percentage and anterior and 1.2 percentage, totally 10.2 percentage, which is comes under greater than 10 percentage. I will be covering. Then next is like graft preparation. If I'm preparing on the graft means my entire code will be changed, which I will come with the 15002 series, right? You remember 15002 series? It is like we depending on the size here, 175 centimeter they have provided. So then it should be given for 15002 series, okay, which is going to be 15002 and 15003 because the entire size is 175 centimeter square. For first 100 centimeter square, I have the code. Each additional 75 centimeter, I have the separate code. Here, what they're trying to tell is that the prepared for surgical preparation is done, which is like they have taken the grafting. Can you see split grafting is performed here? Okay, so that is the reason I'm not using the burn code here. I'm using the grafting code. Then next is like lead Browner pediatric case. Here in this 3 years old sustained second degree burn in a head and entire leg. Okay, based on the percentage of the burn, head and leg. Okay, we have the separate code, sound in percentage, 5 percentage, where I need to use together 23 percentage of total body surface. I'll be using 16030 greater than 10 percentage of the burn code here. Okay, so these are we will be calculating the different set of codes for the burn. And the next topic is destruction. Okay, this is what I forgot either. Okay, destruction. So destruction is nothing. Okay, they use the method. Okay, like ablations or pre-malignant tissues method to include electrosurgery, curating a cytosurgery or laseration or chemical treatment, which they will be see the small difference. So excision is cut and remove. Okay, excision which they do the cut and remove of the any malignant or any ablations or lesions. When it comes for the destruction, they will disturb that area by using the method like electrosurgery method, like cryosurgery method, like which means liquid nitrogen or laseration chemical treatment. They will disturb that particular area so that they can shave and remove the entire damaged or infected area or lesions. Okay, so based on that only we have the codes. The first lesion we have 17000 for each addition lesion till the 14 we have 17000, 17003. Okay, then 17004 we have to use a separate code, that is more than 15 lesion, and benign 1 to 14 and benign lesion more than 15. Okay, we have separate code for the lesion and benign lesion codes in the destruction. Okay, destruction is just a method to destruct the tissue or destroy the tissue of the damaged tissue or damaged lesion or damaged benign, to damage the benign. Okay, that is what the destruction is performed for. Here, key coding rule, very importantly, the code remains the same whether they use laser or liquid nitrogen or acid, whatever it is going to be, the codes are going to be the same, only based on the lesion. Okay, for the lesion and for the benign lesion, we have the separate code we need to use. Then global period. Most destruction codes have 10 days of global period. What is that? Most destruction codes will have the 10 days of global period. Why? Because after the destruction, it may end up with the infection also. After 10 days, if he's coming means I need to treat for the infection. If he's coming between the 10 days, the global period is coming means I will not charge separately. I will include with the destruction only. Then destruction versus excision. If you cut the lesion out with a scalp, it is excision. Use the excision codes like 11400, 11646. Those are the code range. If you freeze or burn it off, use the destruction code. That is what I'm trying to tell. Incidental treatment. You cannot bill for destruction if it is an innovative part of the other procedure. Okay, when they're doing other major surgeries, procedures, and all, in that the destruction is one of the part of the treatment means I cannot code separately. Okay, that is very mandatory things which we have to see. Okay, then next topic is like mosographic. It is like this is a method used to identify or diagnose the condition. Okay, condition which is like what type of condition he is facing, like what type of lesion it is or what type of malignant or what type of benign he is having. Especially it is mostly used for the basal cell carcinoma, we call it as BCC. Okay, mostly the skin related condition. This is basically performed with the help of two stages. Okay, stage 1 and stage 2. Before that we need something like anatomical location, which anatomical location that need to be performed Then number of stages, whether it is need to be performed in the first stage or the second stage, and depending on the block, number of blocks it is processed. Okay, so if you see in the first stage, what they will be doing means they will take the first layer of the skin. Okay, that the first stage we call it as, and you will put it into the 5 blocks. If we cut into the 5 different pieces and is sending for the microscopic analysis, we have the separate code. Okay, in the first stage itself, he is putting into the 6 block or 7 blocks, 8 blocks, we have the add-on code. For the first stage of the first 5 blocks, we have 17311. From the sixth block, for the first stage, we have the separate block. That is one layer he will take. Then you may go with one more layer. Okay, that is a second stage. You will do the one more cut. Like first plate, you will take and keep it in the 5 blocks or 6 block under the microscopic analysis. And the second time, you will do one more cut, and you may go for same 5 block. Okay, you may go for same 5 block. Okay, so that is we have separate add-on code, that is 17312 for second stage, including up to 5 block. Since they were only 3, this code comes them all. Okay, so it is like the second block they go, so second stage they're going to do only the 3 blocks. We have the block code till the 5, so I can use the add-on code 17312. That is what the blocks and the stage performed. So stage 1, the initial surgical tissue layer, and block means the mounting of the medium and keeping in the, what is that, for the examination. Okay, so we have 17311 17315 codes, which is used for the Mohs microscopic technique of analyzing the basal cell carcinomas, all the carcinomas. Then biopsy on the same day. If the biopsy is performed on the same day as the Mohs, because no prior pathology exists, you may bill biopsy with the 59 modifier, excess modifier. However, if the diagnosis was already confirmed, the biopsy is bundled. Okay, so here how the biopsy will be coded means, say for example, priorly I don't know what type of tissue disease means. That time, if I'm doing the biopsy along with the Mohs microscopic, I can code Mohs microscopic and the biopsy both together. If I already know what is the problem, okay, if I already know what is the carcinoma or malignant, if I already know, in that scenario, if I'm doing the biopsy means I cannot code biopsy separately. That is included in the Mohs microscopic only. That is the guidelines, very biopsy related guidelines along with the Mohs microscopy. Try to remember. Sometimes you get like, sometimes you will get these questions, but along with the biopsy, you don't get only the block and the stage we may encounter these questions. But when you get for the biopsy, please be careful. Mohs codes do not include the repair. Closure should be built separately. Okay, in the Mohs procedures, repair is not included. Unlike other procedures, in the Mohs, this complex repair, flap, grafting, and are not included. We have to code them separately. That is the guidelines. Then the next topic is like breast biopsy. Okay, in breast biopsy, we do have the 2 types of biopsy. One is like a percutaneous biopsy, the other one is like open or incisional excisional biopsy. Open is both incisional excisional, we can consider. For percutaneous biopsy, we have the imaging guidance. Okay, so with the imaging guidance only, we will be able to, based on the imaging guidance only, we will be able to code here. Okay, see here, stereotic, ultrasound, and MRI, separate code. For each, we have the add-on code. For each lesion, we will be having the add-on code. Okay, so percutaneous biopsy is performed in this way. There's one more biopsy, that is open biopsy. It's an incisional biopsy where they'll be removing only one piece of the one piece from the entire mass. Okay, and next is like 19120. It is excisional biopsy. That is incisional biopsy, like small puncture they'll put, small incision they'll put, they'll collect a sample. When it comes for the excisional biopsy, they remove the entire mass, typically for the benign appearing tumor like fibrosis. So that completely they will remove it. Okay, that is a excisional biopsy. One more is like excision of the breast lesion identified by preoperative radiological marker. So here what they will do, here they will use a method, okay, operative radiological method, okay, to identify the, to perform the excision. So that excision, when I open the body and go for the biopsy directly, to after removing the mass, here previously they will identify what type of lesion it is and they'll put a marker. They will keep a marker there. By using the marker, they will do the excision. So this excision we have separate code, that is 19125. So in breast biopsy, majorly we have 2 types of biopsy. One is percutaneous biopsy, where I have the range of code from 190812 to 19086. Depending on the lesion, depending on the type of guidance they used, we have the separate code. Then one more biopsy is open biopsy. In that incisional biopsy and excisional biopsy is there. Incisional biopsy 101, When it comes for the excisional biopsy, two types is there. One is like entire mass is removed for the biopsy. The other one is like they will use the operative radiological marker to identify the breast lesion. That is a one more excision method. Then we have mastectomy. Okay, in the mastectomy, we have two type of mastectomy. One is a partial mastectomy. The other one is the total mastectomy. In the partial mastectomy, there will be cutting like mastectomy means right. So they will be removing the part of the breast. Okay, that is what called as a mastectomy. Here, when it comes for the partial mastectomy, we have code where they will be taking any one quadrant or any one lump. That is called partial mastectomy. With the partial mastectomy, they do the axilla, which means the armpit underside is there. No, if they remove that, means that becomes axillary lymphodectomy. So we have the separate code for that. Partial mastectomy one code, partial mastectomy with the axillary lymphodectomy, we have the separate code. Then total mastectomy. Total mastectomy means it is like they're removing the entire breast, removal of all breast tissue, nipple, alveolar region. Okay, including they will leave out the pectoral muscles alone entirely, completely they will be taking. We have the total mastectomy code of 19303. There is one more, removal of entire breast and lymphatic node, like how we saw for the partial mastectomy. In the total mastectomy also, along with the axillary lymph node, if they remove, that will become the modified radical mastectomy. There is one more code. Then one more is like a patient, like male patient, especially it is performed gynomastia. That is a defect, like they will have the what is it, a breast-like formation in their chest, the trunk area. They will remove that. Okay, that mastectomy breast removal is called we have a separate code for that. That is 19300. Gynecomastia. We call it as gynecomastia for that. Then we have based on the implant, some codes are there, that will be last codes. Okay, that is implant based reconstruction, immediate implant, delayed implant, tissue expander. Okay, these are the three types of implants will be done for the mastectomy patients. Okay, immediately after the mastectomy, if they do, that is the immediate implanting, and we have the code 19340. Then one more is like insertion of permanent implant on the separate day from the mastectomy, which is like they will do the mastectomy today, 1 or 2 days after healing, after it is getting completely healed, they may ask you to come back again. They may insert the implant. Okay, that is one more type, which is called delayed. And the third one is tissue expander. Okay, if you see the tissue expander here, when the tissues will be, can you see the downside one picture is there? Okay, there what they do, placement of the temporary expander, okay, immediately are delayed to stretch the skin before the permanent implant. So it is like they will, after doing the mastectomy, they will stretch the skin. Okay, that outer layer, they will expand that particular tissue. Okay, then after some days, okay, the second stage, how what it happens, when you're replacing the tissue expander with the permanent implant, use 11970. Okay, so not 19342. So especially we have the two set of code. Okay, when I do the tissue expander, along with that, immediately if I do the implantation, I have the code 19357. Okay, if the tissue expander is done after some days, okay, if I do delayed implant, in that scenario, I need to go with 11970. Okay, these are the different set of implant based reconstruction for the breast. Okay, apart from that, we have one thing called revision of the reconstructed breast, which means already they have placed the implant, they will do the revision for that implant. Okay, so that is what called revision of reconstructed breast. So we have only one code, that is 19380. We have certain important criteria for that. Those are significant removal of tissue for the contouring, then a re-advance or resetting the flap in the previous autologous reconstruction, significant capsular revision combined with the soft tissue excision. So these are the clinical indicators, like how I am going to do the reconstruction, what are the scenarios, what are the scenarios I can do that, what are the reasons I can do that revision of the reconstructed breast. Okay, then autologous flap reconstruction. Here we have different types of flap. This is involved in the patient own skin and fat, sometimes muscles also. First thing is like dorsoflap from the back side. If they do the flapping, that is a dorsoflap. And if they do from the microvascular surgery, which is like free flap, we call it as anywhere they can able to take the flap, that is also called free flap. So if they do that method, we will be going with the 19364. Okay, and one more is like 19367 to 19369, that is called tram flap. Okay, tram flap is nothing from the trunk region abdominis muscle they will be taking. So can you see the above picture? There they will be able to take the muscle and they will be replacing in the breast area. That is called tram flap. Okay. So depending on the flap where it is done, we have the separate codes for the breast reconstruction. So implant of reconstruction, revision of reconstruction, and auto revision of reconstruction. Okay. So these all are the topics. Okay, which is there for the which is there for the integumentary system. Okay. So far any clarification if you have, or if you not clear with